Hello and welcome to this session. And this session is all about acute trauma, acute hindfoot trauma, and complications related to this acute hindfoot trauma. We have galaxy of speakers from Indian continent. The first speaker is Dr. Shivam Shah, who has been a young and energetic foot and ankle surgeon who is a joint director of Advanced Foot and Ankle Center, Marengo Asia Hospitals, Baroda and Surat. He has had his ankle replacement fellowship, arthroscopy and endoscopy fellowship, MIS foot and ankle fellowship. He is going to talk onto his case onto acute hindfoot complication in the case of talus fracture dislocation. The next is Dr. Dharmarajan, who is director of an Institute of Foot and Ankle at Parvati Hospital, Chennai. His area of interest is complex foot and ankle trauma and deformity correction. He has established Institute of Foot and Ankle at Parvati Hospital in Chennai, which is the first exclusive center of foot and ankle problems in southern part of India. He has organized many summits, and the very famous summit is National Foot and Ankle Summit in 2019-2025. So now I would stop sharing my presentation and I'm going to give it to Dr. Shivam.
Hello, good afternoon from India. My case is on neglected trauma case of talus fracture. Now is it visible? My screen is visible now. Yeah. It's a case of a 24-year-old dentist who had a fall from height, had an open injury and traumatic exclusion of talus. At local center, just the suturing was done. This is the presentation on day 4. As you can see, it's a Hawkins type 2 parietal dislocation with extruded talus. At day 4, another debridement was done. Talus was put back, X-fix was done, and talus was fixed with the KYS. Then infection set in. He undergone 2 debridements. K-wire were removed, and patient was now in a condition of sepsis. So this is how this patient presented to our center. So what next is a toxic patient and undergoing sepsis, 2 failed debridement and pouring pus coming out of the wound. So then this patient presented to our center. First stage, we did a thorough debridement in which all the necrotic bone, entire form of talus and a part of the calcaneus were removed, and a defect of about 12 centimeter was created. So this is how we ended up. Now the question is how to bridge this defect. So after this, we thought of doing Elizarov reconstruction. So Elizarov was done, corticotomy as well as lengthening, followed by bone grafting and docking. So after Elizarov 1 year, this is the clinical photograph and this is the X-ray of the patient. Now, what would be the further management? Next, he was given a brace. He was back in action, but he came back after 19 months of the fusion, complained of painless instability and a fall. This was his clinical picture, and this was his X-ray. And this is how he walks. Right. So at this point, I would like to ask everyone, what would be your next step of management? So at this point of time, we ended up doing a fusion, lateral approach, plate and bone grafting. We ended up doing a calcaneotibial kind of a fusion with bone grafting from the fibula, and this is how we achieved the union. But the story does not end here. He comes back just 1 month prior, complaint of pain of the lateral border of foot with cons and callosity. So this is his clinical photograph. And this is his X-ray. So as you can see, there is a very good union, but some form of varus deformity at the heel, which is causing a non-healing ulcer at the fifth metatarsal head, for which maybe further he would require corrective osteotomy. Thank you so much.
Afraid others could see his presentation. I could not see his presentation.
Corrective osteotomy done?
Not yet, not yet, not yet, sir.
So, did you not use Elizaro from beginning?
So in the beginning we had done serial debridements, and the fusion was at the time of fusion we had done the Elizarov procedure.
Okay. And when you docked this fusion, did you put in a bone graft or you did not?
Yes, we did put a bone graft at the time.
So you put in a bone graft. And the most important was
What is now the presenting complaints, Shivam?
So now the presenting complaint is a non-healing ulcer over the base of the or the head of the metatarsal. Maybe because of the residual varus deformity that has been there at the heel. Right now we have offloaded the patient with a shoe raise as well as offloading the shoes, but the axis need to be corrected so that he would have the healing of the ulcer.
Yeah, Kumar, you had a question.
Yes,
Any
my comment, sir.
displacement kind of osteotomy.
Yes,
Calcaneal osteotomy.
that can be done. That can be done.
No.
So,
but
sir,
then-
can I make my comment, sir?
Sure.
yeah,
sir.
go ahead.
Yeah. So, first of all, it was a very difficult case because the patient was in severe sepsis, as you told me, and the picture is also bad. So, first of all, congratulations on managing the wound. You could manage the infection and get a limb without infection. That itself is a good success. But maybe while the lengthening was done and you could achieve the fusion, and later on when you did the plating, these are difficult problems. They are not very easy to solve, but somehow the ankle was fixed in some angle of varus,
Yes.
and that varus is causing you the problem.
Right.
Now, we need to correct that deformity. We need to correct the deformity in order to get the patient rid of his perennial problem of callosities and ulcers. So maybe you'll have to remove the implant and at the same time do a kind of corrective osteotomy so that he can get a perfect plantigrade foot.
Plantigrade foot.
That
Yes.
will be the solution.
Yes.
So can I add
And another problem is because of lot of scarring, minimally invasive also
Yes.
is ruled out.
MIS better option.
Calcaneal osteotomy. My suggestion may be this thing bit conservative, but it can be done in a two-stage procedure instead of metal exit and some kind of antibiotic beads or this thing can be kept, and then wait for some time, allow the ulcer and infection to settle down, then go for deformity correction, which you can come out with end surgery, probably. Hope so.
Yeah.
In a
How-
very difficult situation,
how
because
often?
nothing is there, a soft tissue
Yeah.
component.
So how often you all have faced this
Sir is
problem?
there, because sir's comment.
Yeah.
Rajiv sir.
So suppose you do the Elizaro, you put in the brace for the time which is double the time it took for the union. And still, when you remove Elizaro, when you put in brace and when you remove the brace, you find fibrous union, something like what Dr. Shivam had. So any experience about that?
Yes, sir. Actually, once
Kumar,
am I
You
am I
had
audible,
such
sir?
experience?
Yes, Ramakanth.
Yes, sir. Ramakanth here. Yes, sir. Actually, there are two things with acute injury. There is an infection. So first thing is to ward off the infection.
Dharmarajan, you had such an experience after removal of Elizaro. after protection also, it goes into non-union, fibrous union.
Continue, Ramakanth.
Yeah, sir.
Okay,
Rajiv
Dr.
sir, you're
Shivam,
not able to hear me, sir.
do you?
Sir
I think
is
that.
not
Actually,
connected.
Dr. Ramakanth sir is making a comment. Sir, please.
Uh, yes, sir. Nothing, sir. We have seen that. So first thing is to ward off the infection,
Ramakanth sir is
get
not
the
audible.
alignment. Okay, am I audible, sir?
Yes, yes,
Now,
you're audible. You're audible.
yeah. So once we get rid of the infection, the thing is to
If it is
maintain the
not audible,
alignment. So we have been using the cement spacer and then just steam and pin to maintain the alignment. And once the infection is got ridden, then we can try to go and do the bone graft and fixation.
Yes.
So probably the Elizero can be avoided, but of course the Elizero gives the robust stability to maintain the alignment. So that is I think Rajiv sir is not able to hear.
Yes, 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 yes. Sir, Ramakanth sir, how is your experience with allografts in such situations to bridge such big defects?
Uh, Allograph, we do have allograph, but very skeptical to use it because if we really want to use the allograph, we have to take like intraoperative cultures and then prove that there is no infection. And only if there is no infection, then we can go ahead. But I have used one case allograph I've used for old infection around the ankle, but then it has come out again with the infection. So just one case I've tried it, and since that kid got reinfected, so I've stopped using allograft in old infected cases.
Okay.
Others are able to hear me because Rajiv Shah sir is not.
Yeah,
I
you're
think.
able to hear.
No, Ramakanth, we can hear you very clearly. You're audible to me.
Okay.
Yeah, we
Okay.
listened the entire conversation.
Yes, sir. So generally, what about Kumar sir and Dharma sir? You use Elizero for to get rid of the infection, or just
I don't.
stabilize along with the.
I
No, I
don't.
have not used Elizarov for foot and ankle so far. I have used for tibial fractures, not for talus fracture. But this was a good way. Sometimes the Elizarov really helps in getting rid of the infection, but there are since various other ways to kill the cat as well. So maybe one thing that works in my hand may not work in yours, and something that is very good in your hands may not be good in mine. So yes, that is what. But as of now, I have not used foot and ankle Elizarov yet.
Yeah, that's
How
true.
about using the cement spacer just to maintain the space and get that the layer around it?
Yes, we
Correct.
do.
Muscular technique in a way. So yes, probably I would have done the same. Maybe put a cement spacer so that illusion of antibiotic is there, and so that a very high concentration of antibiotic is achieved locally, and that takes care of the infection. But here the problem is that Dr. Shivam could achieve the union. He could get rid of the infection. It's only probably because of the varus angulation. Now the patient is having problem in callosity. So I think that's why I congratulated him as far as getting rid of the that very sinister infection was concerned. He could do that. But now, because it was itself a very tough problem, now the major part of problem has already been taken care of. Now the smaller part is to correct the alignment, which he very well can now as a second or third surgery maybe.
so Dr. Shivam, it was because of your plate, which was with the screws, which were a non-locking screw.
Yes, yes.
That's why it gave you. Now, to me, keeping this plate also, you can go ahead
And
and
do
do
MIS.
the osteotomy of calcaneus and really, do the lateral shift, and then varus can be corrected. So that was a good case. Thank you very much for presenting such a good case.
Thank you, sir.
And now we will switch to Professor Dr. Dharmarajan sir.
Anyhow, Shivam, it's a tough case to manage and come out.
Thank you, sir.
Okay, so let's stop sharing your screen, Dr. Shivam, and Dr. Dharmaraj, can you start with your presentation?
Is it visible now?
Yes,
Yes, it
now it's
is.
visible.
Yeah. Good afternoon. Thanks for the organizers and the broadcasting people for this wonderful session. This case is a 28-year gentleman sustained road traffic accident. He had a complex injury on his right foot and ankle, non-diabetic, no comorbidity, and an active male. Clinical examination, there is a swelling, tenderness, deformity, and there is a deep abrasion uh, on the lateral side of the foot and ankle. And he came to the hospital with this, and there is no neurovascular deficit also. And the X-rays are showing this. Uh, what are all the things? Am I audible, Ramakanth? And
Yes, sir.
yeah, what
Yes,
are the
sir, you
things?
are.
Yeah,
Yeah.
play the
Yes.
X-ray. What are the things seen? There are a few small fragments around the ankle.
There is a talar neck fracture, sir.
Okay.
Because the screen is very small, we are not able to
Yeah.
identify.
Okay. There is not a neck. It is the dorsal
Head.
navicular dorsal
It's a
displacement.
loss of displacement of navicular with probably calcaneus cuboid joint dislocation.
Yeah.
Yeah.
Yeah. There is at the first look, it is a peritalar dislocation, where on the right side there is some small fragments on the medial side of the talar head. What is interesting is on the right extreme picture, in front of the cuboid, something is seen.
Yes.
Yeah. In the X-ray, so we can conclude that there is a dorsal, dorsolateral peritalar dislocation with a small fragments near the talar head, and down 2 centimeter down the medial malleolus, there is another fracture, probably something from the talus or calcaneus. On the right extreme picture, there is an anterior process of the calcaneus.
Yes.
And next investigation,
Probably a CT scan.
yeah. So these are the components of the X-ray diagnosis. There is a navicular cuneiform dissociation, a navicular fracture, calcaneal anterior process. And this is the CT, 3D. The other cuts not available. Yeah. CT findings are there is anterolateral peritalar dislocation. Buccal fractures are navicular, sustentaculum, as well as anterior process of calcaneum. I would like to throw the question how to move about either a close reduction, attempt of close reduction. Will you be do this in a peritalar dislocation or straight away go for open reduction? If open reduction, any staged procedure. Opinion from the forum.
Sir, it needs definitely open reduction and get the joints reduced and bones aligned, and then definitely we'll need the fixation. Maybe two different approaches we have to take because the anterior process is towards the lateral side, and we have to take the medial approach as well.
Exactly. Okay. Shivam, do you make an attempt for a close reduction or
I would do a stage procedure. First of all, I would like to put an external fixator spanning the midfoot, uh, try to distract and try to reduce it. Uh, that's what I would feel because acutely we have to go for two incisions. which may not be possible with that much amount of swelling. So first, I would treat it like a stage procedure. That's what.
Okay. Where placement of pin, Shivam?
So I would do both sides, medial as well as lateral distractor. Medial side, calcaneus and the first ray, and the lateral side, calcaneus and the fifth
Just
metatarsus.
like lateral column distraction.
Yeah, lateral and medial both columns I would distract.
Distraction.
Yeah.
Kumar's?
Unfortunately, sir, I'm not able to see your screen. It's just in the small part in the center of my screen. So if you could really get the X-ray back, it's coming in such a small way. I'm not able to make out the X-ray properly.
Okay, I'll do
That
that.
is how
Yeah,
the session is. It's going to be small only. The,
yeah. So let me see the X-ray because I'm not able to see. Yeah.
Is it okay now?
So yeah, the X-ray is there, but it is only in the middle in the small part. Let me peer very closely. So what I can see is, as you rightly say, peritalar dislocation. And you took the CT scan, but you have shown me the 3D CT scan. Sometimes 2D cuts are even more informative to the surgeon.
Okay.
But this requires, and naturally, an open reduction, and we need to restore the column length so as
Yeah.
to give a proper functioning painless mobile foot. So restoring the column length and getting
Okay.
the bony alignment will be my goal of my treatment.
Yeah, exactly. That has been done. Like it has been done like what everyone suggested. It was a staged one, and close reduction was not attempted.
okay.
It was a wise thing to do, not to attempt close reduction because you may
Yeah,
actually
there's
jeopardize.
already a nutcracker effect on the all around. Yeah, this is the way. Then on the medial side, there is a spanning fixator on the medial column where um, sustenance, everything is addressed on the medial side. Lateral side, I didn't touch. Convince the patient that it will be on a stage because there is a deep aberration also. Sustentaculum tali also done with the fully threaded cancer because the incision was extended beyond the zones of injury. Comments on the fixation.
So it appears that you have been able to restore the length of the medial column, which
Yes.
is a good thing. That would have been the primary goal of mine, which thankfully you have achieved. But since the pictures are so small, I'm not able to make
Yeah,
out
that
the
is a
actual.
difficult technical technical difficult. Yeah. Okay. Now this is the other.
Mhm.
There is 6 months follow up. He has got some sinus torsade pain because I just patients also not willing to go about for the second surgery. He also wanted to wait and watch. All these fractures got almost united. The navicular sustentaculum tali is well united. Nothing on the this thing. Then navicular got united. Uh, so we are about to remove the plate or to do on the lateral side how to go forward this stage. Pain on the sinus tarsi. Anterior process not united. What to do?
So after 6 months, definitely it needs the fusion of the calcaneal cuboid joint, I think, because it is kind of non-union to malunion kind of
Yeah,
picture is there.
yeah. Fusion of CC joint.
CC joint, yes, sir.
Yeah. And anterior process can be excised or fixed or
It can be trimmed and then it can be, incorporated into the bone graft.
used as a graft.
Yeah, used as a graft as well.
Okay. Kumar?
Yes, sir. Similar.
Yeah,
Yeah,
thank you.
we would need a fusion, but would it be a distraction fusion or
Yeah, yeah,
PNCT
it will be
fusion?
fine.
A distraction.
Ideal is a distraction. If at all, if I want to touch, it should be like a length, I mean lengthening of the lateral column
Yes, exactly.
and a fusion. So the anterior process can be used as a graft. That is what I was thinking. somehow he didn't turn up.
That is
So
the
he
problem.
wanted only the metal exit to be done. Small fragments I left it alone when the plate is removed, and some signs of anterior process is getting close to the calcaneum. But again, he came back with the persistent sinus tarsal pain. Now, as we suggested, same thing was in mind. Luckily, he came after a very long time. He has some early asymptomatic arthritis, anterior process of calcaneum united. Nature has worked, and the patient goes back to his work clinically. This is the follow-up X-rays. Let me have a. This is a recent X-ray. Is a technician working in an industry, comfortably walking now. Asymptomatic. Yeah, the key points is just very rare, but the morbidity is very high. Occult fractures are often missed. CT is to be done, planned for surgery. Both the columns should be addressed. If at all there is no aberration in the patient, I would have operated on second week or third week, and the arthritis of these fractures are common. These are some literatures. Over to again panelist.
Yes, sir.
So, am I audible, Professor?
Yes.
Yes. Okay. So, when you do such a surgery, how do you make sure that you have established the column length perfectly? Intraoperative confirmation that you have nicely established length of both the columns.
We can compare it with the normal side.
Yes, that's what.
Yeah. So, and how do you confirm with the normal side?
We can drape and paint both the legs at the same time and then
Excellent,
do it.
excellent. Sir, did you do that? Because unless you drape both the limbs, you really struggle to understand whether you have really lengthened the both columns and both column lengths are same. Dr.
Yeah,
Dharmarajan?
yeah. My first aim was to address the medial column. There is fractures, small fractures here, small fractures there, and small fractures everywhere. So my that time my thought process was to fix all the small fragments, whatever comes in my view of medial side, like uniform, talus, sustentaculum, everything, and the bridge plating was done, and I checked with the X-rays, so I was satisfied with I could have fairly achieved on the medial side. While coming back on the lateral side only, my plan of action would have been deferred. What you said, the foot, when there is something shortening on the lateral side, there will be a pronated foot like that. So I was waiting for the second stage because of that aberration didn't yield. That is why I was taking long time.
Great case. Any other comment from anybody?
No.
So if that is not there, can I request Professor Dharmarajan to stop sharing his screen
Yes, sir.
and it could be over to
Yes, sir, you can go ahead.
Yeah, this is a 30-year-old female patient. I am housewife. She had a heart TA, sustained a two-wheeler pillion rider, where her foot got into the rear wheel of the uh, two-wheeler. Initially, she had a native treatment for a while. for a short period. Then, because of intolerable pain and swelling, she came with this picture. The screen is audible.
Yes, sir.
Yeah.
Yeah, the talus is moved
Okay.
laterally.
Can I interrupt you? If
Please.
Dr. Ramakant and Dr. Kumar are able to, present
Sure.
the presentation, we can always go ahead, and then we can, if you have time, we can take Dr. Dharmaraj's case. Is that okay?
Okay, sir.
Yeah. Ramakant,
Sir, can
if
I
you can
share my
share your
screen?
Yeah, we're not seeing it. Yeah, and I think it's Professor
Yeah,
Dharmaraj's
I'm
case.
just trying to share my screen.
I stopped sharing.
So I will go about the history of this patient. Sorry for the hiccup. So this is a 27-year-old male with pain and deformity for 3 months. Actually, he had history of fall, the pain, history of trauma about 9 months back following a two-wheeler accident. He has shown to the local hospital and he was diagnosed to have fracture neck of talus, and he underwent ORIF with the screws. But then he came to us 9 months after the surgery with severe pain and deformity. So, sir, can you see the X-ray? This was his index, X-ray, where he had the injury of the talus. He was diagnosed to have talar neck fracture, and there was a subtalar subluxation was there. So can you appreciate this, sir, in the X-ray?
Yes, sir.
Yeah, not that clear, but yes, it's a very small window showing the presentation.
Yeah. Yes, sir. So this was the thing what he presented to us after 9 months following the injury. Before showing the clinical picture, I just want to discuss about this fixation, sir. So can you comment on this fixation which was done elsewhere?
Can I
Kumar,
start?
Kumar,
Yeah.
please.
So maybe everything that could go wrong has gone wrong, if I could put in a one word, because in the lateral view, first I'll start my comment from there. The screws, first of all, fixation itself is poorly inadequate.
Yes,
Second,
sir.
the screw that has been put in the lateral view, we can see it's not crossing the fracture in any sort of way. The other
Yes,
screw
sir.
that we can see in lateral view is not of adequate length. But because since the picture is very small, what I can make out is probably even the reduction is not proper. What we talk of
Yes, sir.
fixation. So for this union to occur, there has to be a proper fixation, and the the dislocation that has not been corrected either. So that is what.
Yes, sir. So as we can see the ankle AP view, the end-on view shows that the huge lateral aspect, there is a huge opening is there. And to start with, the primary reduction of the head to the neck of the talus was not done. As I marked out the head and the remaining portion of neck and the body of the talus, we can see that the screw is just passing from one lateral portion of the head to the neck, and the another the headless screw is from the head to the neck, but then there was no reduction of the fracture was there. So it was a head neck junction, it was a split fracture, and there was a subtalar subluxation was still present. So this is a comparison with the normal X-ray, where the end-on view of the calcaneum in the ankle AP view shows that calcaneum is supposed to lie immediately below the talus, and in our X-ray we can see that it is subluxated medially. The whole component along of the foot along with the calcaneum is subluxated medially, and we can see that there is a large gap is there. And these are his clinical presentation. Understandably, the hindfoot is in varus, and the forefoot is only the lateral border is grounded, and the medial border of forefoot is lifted off. And here we can see that there was a huge swelling. There was subtalar movement was painful and it was fixed, and the ankle movement was there. about 10 to 15 degree was there, and this was his gait. So it was a 9 months old injury. The varus thrust and disabling gait. So, Kumar sir or Rajiv sir, what can be done at this stage
Yes.
with
So naturally,
a full varus thrust walking and disabling gait?
so we need to remove the implant, use a
Yes, sir.
distractor device, bring the two fragments in a proper reduction, and then fix it. Because even before we can think of any fusion, we need to have a proper bone block in position. So we must first try to bring the still displaced bony fragments in right proximity and then try fixing it. Although because it is such a the injury was such a long back, and there must be I mean the tissues will have problem in stretching. So per op, you need to have a distraction device.
Are these screws titanium one or they are the stainless steel one?
The stainless steel screws, sir. They had put
Mhm.
one headless screw and one, the
Um,
4.5 cannulated screw.
Very difficult to get an MRI. In my plea and my advice to everybody is always for a talus fracture, use titanium screws. The use of titanium implant would only allow to you as well as to the next person to go ahead and get an MRI done.
Yes, sir. So, what would be the mode of plan now, sir? With the patient is walking with a painful disabling gait and a varus thrust.
Yeah, the problem is now there is a implant which is causing problem. There
Yes,
is a
sir.
non-union element is there. There is a
Yes, sir.
subtalar dislocation is there.
Medial
So,
dislocation. Yes, sir.
yes, yeah. So, uh, given to this neglected 9 months old, the doubt of avian is also there. So, removal of implant, a double fusion, medial side, a plating, and on the lateral side also, a double fusion uh, to be the ideal subtalar fusion and medial column fusion.
Yes, sir.
May
Yes,
that
sir.
is my with the bone grafting definitely.
Yes, sir. Dr. Shivam?
So he had to go.
Yeah.
Oh, okay, sir. Okay, sir.
Kumar,
Sir, can you add on further what are the further investigations needed, or how to
In
go
case
about this case?
A CT scan,
Yes, sir.
CT scan would be helpful.
So the MRI also was done to know the viability of the talar body, and these are the screw artifacts from the stainless screws, but there was no avian of the talus. Luckily, because there was a head neck junction fracture, so not pure neck fracture. And these are the CT scan which shows comminuted fracture, and this is a 3D scan where we can see that the subtalar is still subluxated on medial side. The whole calcaneal component along with the foot is displayed medial side, and what we can see also in the CT scan is the portion of head is there, but it is lying lateral from lateral to the navicular articular.
Yeah. So did you plan open reduction, dual approach?
Yes, sir. So the ideally was to I tried for the reduction of head fragment to the remaining portion of head which is not fractured.
Ramakanth, the
It is
voice gone.
yes, sir. Now can you hear me, sir?
Yes.
Hello.
Go ahead.
Yes, yes, sir. So there was a head neck split fracture. The head was not completely split. Portion of head was lying with the neck and the body. And my aim was to reduce the head and neck and then try for a fixation, and also at the same time lateral side opening and then try to reduce the subtalar joint, sir. So that was my plan.
There's hangover.
Sir,
I,
anything else you want to add at this stage? So
I,
before
I think we have another 2 3 minutes.
Yes, sir. So
So
I
this
will
should,
go ahead and tell what I have done. So this is the varus thrust grade, and the plan was to do
Yeah,
open
you described.
subtalar subluxation, open subtalar
Can I
joint.
quickly try running through my presentation very quickly, sir, if you allow, or
yeah.
maybe the presentations?
Sir, can you not able to hear me?
No, no, go ahead. Finish it.
Okay. Okay, sir.
He has
So
to
that
stop
was
sharing,
planned
sir.
for it. So since it is a neglected case, so
Ramakanth
the
has to
subtalar
stop
fusion
sharing.
was done. Subtalar fusion was done after reducing the subtalar joint, and
Or the
tricuspid
admin
graft was
can make
inserted.
Or
Kumar.
maybe we can just discuss whatever has been presented because hardly there is any time. There's hardly one
Yes,
minute.
exactly. We have another
Yeah.
2 minutes.
So the calcaneum was brought
I
underneath
think he
the
has fused the
talus and the
subtalar joint.
lateral.
I don't
Yeah,
know.
I have
Some
fused the
two
subtalar
wires.
joint,
What
and
purpose it is?
also there was a lateral opening was there. So
Maybe
after
he is
fixing
showing
the subtalar
intraoperative
joint, I
picture.
felt the lateral side. There was a opening was there. Sir, can you hear me? There is a continuous voice interruption as well.
Yeah.
Hello. So what I have done was a ATFL also was done for this along with the CFL reconstruction using
There's
the
used some kind of
peroneus
internal bracing with
brevis.
the tendons
It's a reconstruction, sir, with the tendon.
from the.
So lateral side there was a instability was there. So ATFL and the CFL was done. So along by using the peroneus brevis. And these are the post-op X-rays. The KOS was removed. The head fragment could not be fixed. The joint is stable, and those are the suture anchors for CFL and
Okay, sir. To
ATFL.
conclude, what will be your choice of fixation for this, sir? Rajiv, sir?
The fixation for ATFL reconstruction.
No, sir. This
Yeah.
case, this subtalar with the non-union of talar neck.
Yeah, the fixation would be the same way he had done. But only thing for reconstruction of lateral ligament, I would have gone with the simple suture anchors and reconstructed it.
So this is a
Yeah,
two
but
years follow-up of this patient, sir.
yeah, good.
So from varus thrust grade, we have restored it to the normal.
Excellent. Excellent.
Yes, sir.
Great.
Yes, sir. I
I'm
have to
afraid,
stop sharing the.
yeah,
Stop
we'll have to
sharing.
stop sharing. And I'm afraid we are done with this session. Apologies, Kumar.
No, no, sir. There's always the next time.
Yeah,
There's always
challenging
the next
cases. And thank you very much
time.
for this wonderful
But I
session. The
love being
next
here.
session, it's over to the team who will now take us to the next session that will be driven by Dr. Ajoy.